Hello and good morning, everyone out there in webinar land. My name is Jeff Buckley. I'm the Director of Insight. It's my great pleasure to welcome you to our first Insight APSAD webinar for 2022. It's been a big year already. Before I go along, I'd like to acknowledge the traditional owners of the lands in which I'm gathered here in the Anjin in Brisbane, the Yagara and Turrbal, and all the other lands of which guests are joining us here today, and pay respects to elders past and present. Another big week for our First Nations Australians with National Closing the Gap Day tomorrow. And as part of our efforts here, we'd really like to welcome our first speaker to the webinar program for the year, and it's Professor Julie Ooi. And Julie is a neonatologist at the Royal Hospital for Women in Randwick, New South Wales, and conjoint professor of paediatrics at the University of New South Wales. So to kick it off for the year and for the semester, Professor Julie is going to talk about the health impact of prenatal opioids. So I'll throw it over to you, Julie. In the meanwhile, type your questions in the chat and I'll make sure I ask them to Julie at the end of the session. And I'll see you in a sec. Thanks, Julie.
Thank you so much, Jeff. And I didn't know it was the first one. This is very, very scary. Oh my God. Okay. All right. I see some familiar names on the attendee side. So hi, Caitlin Sue. How are you? All right. So I shall share my screen now and get on with it. Just as an introduction, I am a neonatologist at Randwick, and I've been working with families. Working with families who have been impacted by substance use for more than 20 years. It's really scary. Time flies. And in December 2021, along with Henry Jones and Mishka Teplan from the US, I was asked to be part of an initiative from the UNODC, the United Nations Office on Drugs and Crime, and the WHO to formulate a strategy to look into the impact of prenatal opioids on children in the long term. So I'm leading the health strategy. Henry is leading the education, and Mishka the social. And I'll show you an invitation for a talk tomorrow for the 65th Commission for Narcotic Drugs. Unfortunately, online, usually in Vienna, which we'll be presenting in and which you're welcome to join. So looking at the health problems of prenatal drugs, it wasn't too long ago, that in 1975, when Loretta Finnegan first developed her Finnegan score, there were concerns that prenatal exposures could affect the developing child. And back then, it was said that it was really important for us to study the long-term effects of the drugs, but on the central nervous system, bearing in mind that we know what we use drugs for. We use drugs to change what we perceive, what our mentation is, and what our mood is. But fast forward a couple of years, and in 1989, almost 20 years later, everything was really hunky-dory. There were no concerns for prenatal substance exposure, although maybe the developmental scores were a bit lower than the unexposed child, but it wasn't a big deal. So that was the premise we were working in for a few decades. Now we're concerned that prenatal drugs may cause long-lasting developmental changes. And why is that? So for hundreds of years, we weren't concerned about what happened to babies of moms who use antenatal substances. The most immediate concern of prenatal drugs is withdrawal in the newborn infant. So otherwise known as neonatal abstinence syndrome, NAS, with newborn withdrawal is not a new problem. It was first reported way back in the 1800s in babies of moms who used morphine, and it was called congenital morphinism. Ladies use morphine, and it was well accepted that many women use morphine for their health. But underlying this was a dark, background. It was also well known that this withdrawal syndrome happened in a few days in otherwise normal babies. And if the babies were undiscovered and untreated, most of them would die. So in one of these very sad cases, one mom had 16 babies, 15 died within a couple of months of life. And the only one that survived was the last one when they figured out, oh, maybe he may have needed a bit of morphine. So he survived with a couple of drops of morphine as he needed it. So for decades, we focused on treating NAS because it was a devastating condition. More than 90% of the babies who had untreated withdrawal would either die or develop serious complications like seizures and failure to thrive. However, NAS treatment has now improved, as you all know, and babies seldom die as a direct cause and seldom die from NAS. So our concern is what happens to these children. And as you all know, you're all in the field, finding one of these children is crazy. There are thousands of them born every year. In New South Wales, we estimate about 1.5% of babies, which is about out of our 100,000 births per year, are exposed to prenatal opioids alone. And that's not counting the methamphetamine babies and the babies that are exposed to other substances. Many of these babies, as you know, are extremely healthy after their withdrawal or intoxication is sorted out. So acquiring data is extremely difficult. These children are very mobile. They may go from home to home. They're difficult to engage because of their family circumstances, and especially because many of them are very healthy. Once you sort out the immediate newborn problems, they appear perfect. But prenatal drug exposure is the archetypical or the classical iceberg problem. What you have is the very visible on top of the waterline there, the neonatal abstinence syndrome and the many pregnancy problems that sometimes our women have. But underlying that are things that may take years to emerge and makes it very difficult to connect the prenatal exposure to these problems. So I won't go through them. You guys know all about these ones. So what is concerning is that you have to remember that all the drugs cross the placenta. Anything mom takes will cross the placenta. And not all drugs cause abnormalities like alcohol here. So these are two little babies that died at 6 weeks. On the left is the brain of a normal 6-week infant. You can see how well formed it is with lots of gyri and sulci. And on the right is the brain of a mom who used alcohol, brain of a baby of a mom who used alcohol. Not many of our drugs are obvious neuroteratogens like alcohol. But we know that prenatal drugs have the greatest impact at the time of the most rapid brain growth and development, and that's during gestation, especially in the second trimester and the first few months of infancy. So we'll focus on opioids, but other drugs have similar problems. So opioids will disrupt how the dendrites are formed. They impair myelin production, how long the dendrites are, and how many branches your axons have. So many of the animal studies show that opioid exposure will lead to short symbol dendrites. Opioids also increase neuronal death by apoptosis and necrosis. Indirectly, they can cause potential hypoxia to the brain and the vital organ of the placenta by increasing vascular contractility. And through opioid receptors, which are negative growth factors, they stop the baby from growing. So many of our babies are born small with small heads. So does that matter? The drugs also selectively cause neuronal death by apoptosis, which is programmed cell death in certain areas of the brain. So in this experiment, laboratory rats were given intraperitoneal heroin and an injection into the abdomen. And what they did when they sectioned the brain out, they found that the hippocampus, the part of the brain that's particularly concerned with memory, was affected by increased apoptosis or cell death. So what we hear commonly in parents or carers of children who have been exposed to prenatal opioids is that our children have difficulties remembering things and they need a lot of help just remembering how to process and how to retain what they've been told at school, for example, or little simple tasks. Furthermore, the drugs act on endogenous neurotransmitters. So these are the substances that's made in the brain from simple precursors like amino acids that tell your brain cells what to do. These things are readily available in a diet. And as you know, sometimes the diet of our moms are not sufficient. The neurotransmitters are made deep in the brain in parts called the brain reward centers. And prolonged drug use will increase these brain reward centers to make more and more neurotransmitters. And sooner or later, these brain reward centers will become exhausted. Opioids and other agents are also potent inflammatory mediators in the peripheral system and also within the central nervous system. And just focusing on opioids again, what we know is that opioids will increase neuroinflammation through opioid receptors, endogenous receptors such as the TLR4 receptors, and they activate the glial cells, which in adults is associated with opioid tolerance and all the side effects of dependency. And again, inflammation in the brain is associated with other problems such as maternal health issues, stress, and poor nutrition. So this is a very busy slide, and you can see that what affects a baby who's been exposed to prenatal drugs is not just the drugs itself, which is tucked way up into the left-hand corner. So these little babies are exposed to the drugs, but they're also exposed to stress, sustained peripheral hyperimmunity, environmental stresses, oxidative stress, problems with the mom's inflamed, they have epigenetic programming, cortisol dysregulation, and right down at the end is us. If we don't find these babies, if we don't provide the intervention and the support, it leads to the bottom. It leads to the bottom where the brain continues to grow poorly, continues to function poorly, and the baby has poor life outcomes. So what happens in real life? We can't cut open the brains of our babies to have a look inside. So the next best thing is we do an MRI. So this is a very, very occupational health and safety hazard. We did know that when we took the photo. So what we did was we did MRIs on 32 babies. We didn't have money to do more. Babies who were exposed to prenatal opioids. We wanted to see what was inside their brains. We hypothesized that since opioids were not known to be structural neuroteratogens like alcohol, these brains would be absolutely normal. However, we hypothesized also that due to what we knew about how opioids impaired brain growth, these babies would have smaller brains. Because we didn't have the money to look at normal baby brains, we divided our cohort into two groups. One in orange, where the babies were exposed to only one type of opioid. For example, mom was on the methadone or buprenorphine program. And we compared that to babies of moms who use many opioids, such as those who use methadone and heroin and also assaulted substances. Those are in red. So they will be the same colors for the next slides. So you can see here, these are the brain volumes of the babies of moms who use the opioids. On the left is the volume of the brains in mils. And then you have the orange boxes, the one opioid babies, and the red boxes, the multiple opioid babies. You can see that the babies of moms who use one opioid have significantly larger brain volumes than those who were exposed to multiple opioids. But compared to normal population values, which is the red line there, both groups had significantly smaller brain volumes. And what does that mean for real life? If you look at population studies, brain volume is equated to cognitive function. So these babies have quite small brains. And what is particularly impacted are the basal ganglia or the deep nuclei, which are the seat of the neurotransmitter production. And if you don't have enough enough neurotransmitters as a person, you'll be looking for other things to increase your neurotransmitter load. And they also had quite tiny cerebellums, which is the part of the brain at the back, which helps provide smooth and coordinated body movement, but is also increasingly associated with cognitive development. And what we find in our clinics is that there are quite a few reports of the children coming in with difficulties with gross motor function and coordination, which makes it very tough when they're trying to play or do all the normal things that preschool or primary school child needs to do. So if you look at neuroimaging of children and adults who have exposed to prenatal opioids, there's an increasing body of information that show that there are many problems with them. So things like decreased cerebral perfusion, abnormal connectivity, smaller brain volumes, even until adolescence, smaller cortical surface areas until the third decade of life that's associated with neurocognitive changes. Difficulties are decreased microstructural alterations of the white matter tracts, and again, problems with the eyes, immature visual evoked potentials. So in our population, what we find is that our children have 10 times the risk of eye problems, strabismus, short-sightedness, etc. And if that's not fixed, they can't see properly to learn at school and to grow. So these are quick examples of some MRIs that have been done. Some you often see white matter lesions, which are indicative of previous hypoxia, and diffuse white matter injury. So we did a meta-analysis of cognitive problems of 26 studies a couple of years ago, where we compared outcomes of children who were examined developmentally compared to almost 3,000 non-exposed children. So very busy forest plots here, but the bottom line is that these children who are exposed to prenatal opioids show development problems by the time they're 6 months, and by the time they reach school, their cognitive development is equivalent to almost 8 points lower than other children. So what does that mean in real life? It means that this group of children who are exposed to prenatal opioids are 3 times more likely to be classified as intellectually disabled. I'm not sure whether this video will work, and just ignore Sarah Cluse's voice in the background. But what we are doing now in our clinic is general movement screening, which is a very easy test. Basically, you do a video of the baby at term and at 3 to 4 months, and it's used in all our NICUs to look for children who are at high risk of cerebral palsy and global developmental delay. And this is used by the people look after preterm babies to target intervention because it's very sensitive for cerebral palsy. So we had a look at a few children who were exposed to prenatal opioids and methamphetamines. And out of the 8 opioid babies, what we could find was that only 1 had normal general movements. And you can see here from this video, you would probably not miss that this child does not move much. And this is what we call an abnormal general movement. So early intervention needs to be done very quickly, as you know, and general movements might offer an opportunity to direct babies who are known to be exposed to prenatal drugs for targeted intervention. Okay, we'll move on. So again, in real life, what happens to children, or now increasingly adults with a history of neonatal abstinence syndrome or prenatal drug exposure? One of the most comprehensive reviews that have been published so far is one by Kobrynik et al. In 1956. This group got together almost 200 case reports of babies who had been exposed to prenatal drugs starting from 1875. Out of that group, 26 had died mostly within the first few days of life from withdrawal. Of the live ones, there were 166 of them. He could find a few, but they were quite sad. So 3 were classified as quote unquote addicts. One started at 10 years and all had been treated with morphine for newborn withdrawal. 1 was sickly, 1 was blind, 1 was deaf. And I won't read the comments that was mentioned in this article, but they indicate the stigmatization and the discrimination towards this population. So basically, we really need a life map to find what happens to these children so we can give them the support that they need, because I don't think anyone would argue that prenatal drugs may cause long-term biological change. So to do a life map, what can we do? So we're very fortunate in Australia to be able to have data linkage facilities. So what this means is that we can track people using administrative data, such as birth records with identifiers like names, dates of birth, addresses, hospital numbers. So in this study done by one of my very clever medical students, what we did was we linked birth records in New South Wales to children who had been diagnosed with NAS, coded in the ICD-10 category as P96.1. So that was in hospital data. And we linked that to death records and school records. So as you know, I like to show this slide to the Europeans, showing that Australia is very, very big. So people usually can't run away too fast, especially over the last 2 years. And New South Wales, of course, you have to put it into the US context, is the size of Texas. We only have a very small population, but we have about 100,000 births per year. And due to extremely excellent linkage facilities in New South Wales, currently, each person can be linked up to 8 times with administrative data. So in Hannah's study, what she did was she linked babies, more than 1 million of them, who were born between 2000 and 2011. We are waiting for an update of this data for births until 2018. So out of those 1 million births, we found almost 4,000 babies who had been coded with NAS P96.1 during their birth admission. And we compared that to the babies without NAS, more than 1 million of them, and we tracked them to 12 years. So that study was a few years ago, and we will be waiting for data on these children until the age of 22. Hopefully that will come this year. So we looked at the moms, NAS moms on the left here in blue and yellow, and you can see nothing unusual that is not, nothing unexpected. They were younger, they were more likely to be Aboriginal, they smoked, no antenatal care, and of the lowest socioeconomic quintile. Nothing unusual about the babies during the neonatal period as well. They were more likely to be smaller, preterm, had a poor lower APGARs. 3/4 of them were admitted into a nursery, and they stayed in the hospital 3 times longer than a gestationally comparable infant. But what happened to them afterwards? So we found that children with NAS came back to hospital more than other children. And what did they come back for? Oh, sorry. And the risk of hospitalization, continued to the age of 12 years. So you can see in this risk graph here, my slides are moving everywhere, I'm sorry. The green line represents NAS babies, and the blue line represents babies without NAS. The green line continues to be higher, showing that more of these babies are readmitted after birth than babies without NAS, and this continues to the age of 12, which was the extent of our data at that time. So they came into hospital for different reasons to other children. So you can see here, they came into hospital for things like injury, poisoning, up to 21 times risk of maltreatment, assaults, accidents. And at the bottom there, if you can see, they came into hospitals for these terrible conditions at a significantly younger age, at 4 months compared to 11 months for other children. And this may suggest that they came into hospital because the support services for their families tapered off at that age, after the woman left hospital and everything looked okay. After you took in all the other risk factors for one of these problems, for example, I'll show assault here, you can see that the diagnosis of NAS was independently associated with a 4.5 times risk of a child being re-hospitalized for these problems. And what was extremely concerning was that they were readmitted for evaluation of what ICD-10 codes as mental and behavioral disorders. So things like a very politically incorrect term called mental retardation, speech and autism, behavioral and emotional disorders. But look at the bottom there. The children were evaluated at the age of 5.5 years, compared to 3.5 for other children, suggesting that these issues were not picked up until the children started school. And in a study from the USA by Sherman et al., a review of more than 1,000 children with NAS showed that by the age of 5, 1 in 2 or 50% had been diagnosed with a mental health disorder. So again, after putting everything into a mix in a regression analysis, you can see that NAS was an independent predictor of 2.5 times risk of a child developing mental health and behavioral problems. So the other question that's extremely important, bearing in mind that they come into hospital more likely for assaults, injury, and external problems, is are they more likely to die? And unfortunately, yes. So if you look at this graph, this table here, you can see that the children do not die in the nursery, but they had up to 8 times the risk of death between 1 month and a year of age, suggesting that the risk starts after the children go home. And in this New South Wales data, children with NAS had 3 times the risk of death than other children. And this risk continues to adolescence. This is an inverse of the hospitalization graph. And you can see that the red line representing children with NAS is significantly lower than the blue line representing other children right from the start, suggesting that survival is lower. And again, they don't die from medical problems. Children usually die if they were sick, for example, from a cancer or for heart problems, lung problems, whatever. But these children came in dead. So they died from preventable problems like sudden infant death syndrome, up to 11 times, accidents, assaults, and other things. So does prenatal opioid exposure impact on the life expectancy of the child? Unfortunately, we don't know yet. A study from Alberta, Canada on people with FASD that was conducted between 2003 to 2012 showed that the average life expectancy for a person diagnosed with fetal alcohol syndrome was 34 years, or 42% of the population of Canada. And the majority died from external causes such as suicide, accidents, poisoning, mental and behavioral disorders. Many of them also had cardiovascular and other health issues, but they were in the minority. So lastly, I'd like to end off with what happens at school, because school is one of the most important things that can happen to a child. And if they fail at school, it opens up a Pandora's box of future problems, including physical health problems, mental health problems, and poor adjustment in society. Oh my goodness, my slides are going everywhere. And we know that children with NAS have multiple risks for poor learning, including the direct drug effects on the brain, parenting issues, and social issues. So again, you're all familiar with the NAPLAN, and we use data linkage to find out how these children do at school in the NAPLAN test. I won't go through the NAPLAN specifics because you're all familiar with that. But we know, I guess I have to emphasize that the NAPLAN test is aimed to identify children not meeting national minimum standards. So it's a very basic test, and it's aimed to identify up to 20% of those children who are struggling in school. Exemptions are very uncommon and only given to the extremely sick child or those who have newly come from a non-English speaking country. In New South Wales, the sitting rate is more than 95%. So this is a NAPLAN report that all the parents know and love. It's a standardized test. So it's made out of a score out of 1,000 divided into 10 bands. And what a standardized test means is that at every age, the child's ability reflects a certain performance level. So as the child grows older, the score should go up. So minimum standards at each year level of testing is different according to how old the child is and at what level of education they are. Children below minimum standards are not expected to have the skills to proceed on to the next level of schooling and are considered to be in need of help. So what happened to the NAS children? All right, out of this cohort, we found more than 600,000 children who were eligible for the NAPLAN test at the time of our analysis. And we divided them into NAS children, about 2,000 of them, socioeconomically, gender and gestation match controls, 2:1, and the rest of the population of New South Wales, almost 600,000 in green. So what we found was that children with NAS was significantly more likely than the rest of the population not to have a NAPLAN record. Whether they didn't turn up or whether they changed their names multiple times, we're not sure. They could not be linked. And what we found was that by the age of grade 3, which was about 8 to 9 years old, half of the children had failed to meet minimum standards compared to maximum 20% of the other children. And what is very sad is that if you look at the scores as they age, these scores represents a composite score on the left out of 1,000 for the children, and on the bottom are the grade levels, 3, 5, and 7. You can see here that the NAS children start off in grade 3 having lower scores than the match controls and the other children of New South Wales, which is a top black line, and they remain low. But by the time they reach year 7, their scores are lower than other children in grade 5 who are 2 years younger, which means that as they grow older, their performance deteriorates. So, but the bottom line is that prenatal opioid exposure increases the need for education and support. It's a very, very important flag. Increased education costs may have been shown to be associated even with treatment with prescription opioids. And many governments, including many parts of many states in the US, are recognizing that children who are known to be prenatal opioid exposed need support as they go through the school system. So we know that 1 in 5 of children who are exposed to prenatal substances need disability evaluation, and up to 15% meet the criteria for disability. In Australia, we have no such system in place. So to finish, I'd like to introduce you to my friend Floyd here. This is my other life. I work in the neonatal intensive care unit. So Floyd was one of my first friends. He was born in 1998 at the age of 24 weeks gestation and 500 grams. So in those days, our neonatal care was not as sophisticated as now, and Floyd wasn't given much of a chance of survival and of a good long-term outcome, probably less than 50% at most. And then my other friend here, Robert, he was born in the same year as Floyd and full term, and he had loving parents, Jenny and I think it was David. Both of them were on the methadone program. His chances of survival then was more than 95%, almost 100%, because he had NAS and was treated very uneventfully. And then we look at the scores. So can you guess which of these NAPLAN scores belong to Robert and which belong to Floyd? So if I was in an audience with you, I'll quiz you and ask you to raise your hands. But to cut a long story short, what we did was we compared NAPLAN scores from our database to babies who were born at full term in New South Wales, babies who were born at full term and who were diagnosed with NAS, and babies who were extremely preterm, like Floyd, who had more than a 50% chance of dying in our neonatal ICUs. And our results are very sad. So what we found was that the highest scores belonged to babies who were born at full term, and then followed by babies like Floyd, who were extremely preterm, followed by babies like Robert, who were full term. So fast forward, this is Floyd now. He went on a field trip to Vanuatu, very cranky teenager. And we wanted to know what happened to Robert. Unfortunately, what we do know is that mom has passed away, dad has passed away, and we've lost contact with Robert. So some countries such as the US are pouring in tons of money into ensuring that the babies who are known to be exposed to substances lead a long and healthy life. So the NIH and NIDA have poured 53 million into the HBCD study, which stands for Healthy Brain and Child Development Study, to understand what happens to children who have been exposed to opioid substances and now COVID, to investigate the impact of environmental and other factors and uncover risks for later problems so that strategies for interventions and services can be developed. The next step, we have been working with the United Nations, funded by the government of Canada, to develop a strategy to help babies who have been exposed, particularly to synthetic opioids. And tomorrow, if you have the chance, there will be a presentation by a group at 8 a.m. Central European time, which very fortunately is 6 p.m. Australian time, and sucks to the Americans, 2 a.m., where we will have an hour to discuss strategies to look after children who have been exposed to prenatal opioids. So in conclusion, we'll say that there is increasing evidence that prenatal opioids and other substances impact the long-term outcomes of children, especially in the regards of mental health, neurocognitive, and physical problems. We need to, we know our knowledge gaps, but we need particularly to improve our identification of the infants, to provide interventions that can be sustained for a large population of mothers and infants, and to promote knowledge of this need to care providers, the parents and carers, and especially now, the older children, teenagers, and adults who are looking for answers. So the long-term concerns for adults with a history of opioid and other drug exposure are now one of the greatest global priorities, and hopefully we can work together to help this huge population overcome this need. This is the invitation, and if you want the invitation, give me a yell by email. The link to join the meeting is on the bottom of this invitation. So thank you so much for your time, and I'm happy to take questions.
Thank you so much, Julie, for that presentation. Lots of sobering, stark statistics, unfortunately, for these vulnerable families and babies. Do we have any questions online? There's none at the moment, but while people maybe are considering some questions, I just thought I'd ask you something. Like, are you aware of any programs that are doing particularly well in terms of some of that assertive follow-up with these families or these children, particularly after that 4-month period where they tend to, that postnatal care kind of starts to taper off?
Yeah, so we've been running our service since 1998. Oh my God, I'm showing my age. Where we initially looked at outpatient withdrawal therapy for babies with NAS because with the heroin glut in the early 2000s, we were getting a lot of babies in our NICUs, and we were the first to develop this service. But with this service, we had the opportunity to see our children come back for a very long time, and that's what alerted us to their issues. We noticed that many of them had eye problems, many of them had little subtle problems that really impacted on their ability to function at school. So in our service, what we do is we have a very standardized approach. They come back to see us, and at 1 year, we send them to the eye doctor, we send them to the developmental pediatrician, and we keep seeing them until they hit at least preschool age. Unfortunately, we need more money to promote a long-term strategy. And I think it would be great if, other services could come to develop something like that. I mean, we give a lot of support to preterm children because we know that they're sick from birth, but these kids may have, greater problems than the preterm kids. Oh, so sad, is it? So the comments are so sad. Yes, it is very sad. Yes.
Yeah. Yeah, we do have questions. Is there any difference in outcomes for children who stay with biological parents compared to children who may be removed?
Yeah, Caitlin, that's the major question, because in New South Wales, 1 in 2 of our children are placed into out-of-home care by the time they're 5. So what we're waiting for is data from the Department of Community and Justice. We have received permission to link out-of-home care data to our outcome data. So hopefully we'll be able to tell you. The jury is still out whether placement is early out-of-home care is more beneficial than staying with biological parents, and there's lots of nuances to that, lots of multiple triggers. So what we need to consider as on top of all the social problems is the biological impact of these substances. That does not go away. Yeah. So whether the child's in out-of-home care or with the biological parents, we have to acknowledge that these children have been exposed to intrauterine substances.
Yeah. And do you have data around the level of exposure? There's a question there about intermittent or kind of maybe intensive but brief period exposure. Any comments on that?
Unfortunately, no. I would need about $1 zillion to look at the cohort study. So if any funders online here, we could do something like the HEAL initiative from the US, which has poured in like 50+ million to look at long-term with very, very detailed prenatal exposure data. The Gen V group in Victoria will be collecting biological specimens, and hopefully we can get some correlation between prenatal drugs from biological specimens to long-term outcomes.
Yeah. Okay, it doesn't look like there's any other questions. So apart from obviously investing in a programmatic responses where we do that as sort of follow-up, we wraparound support and ongoing kind of longitudinal support for these children and their families, any kind of basic advice for workers who regularly engage with these pregnant mothers, I guess, in terms of interventions or strategies that tend to be a bit more effective?
Yeah, I think in the cold phase, the most important thing is that we understand and acknowledge the impact of the substance exposure on both the mom and the baby. And it's really scary. When I was doing a grant application a couple of months back, if you look at it, there are about at least 15 specialties that are involved in the care of a mom and bub with substance exposure. That accounts for about almost 750,000 health professionals in Australia, and none of us get any education in this matter. So I remember when I was a fellow, I was roped into our substance use clinic because I couldn't run away fast enough. The other guy was a boy and he ran away screaming, right? So you learn on the job, right? You make a lot of mistakes, and we don't want people to go through the same thing. It's a steep learning curve. None of us get taught about NAS. None of us get taught about long-term outcomes and how to help moms and babies. I think that's the first thing we need to do, education.